Welcome to the MS-Perspektive podcast. Perspective with a K, as I'm German. I'm Nele Handwerker, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins.
This podcast is supported by Mid-Mission, a project of the nonprofit Hertie Foundation.
Welcome to episode number 7, the types of MS, from prodromal phase to progressive course. This time I would like to introduce you to the different types of MS. But be aware, leading MS experts worldwide are increasingly breaking away from these terminologies, as in the end, it is one and the same disease, also with different manifestations. Settling on one of the terminologies listed here can lead to difficulties in treatment options, as most countries have guidelines on which immunotherapy to use for which course. Therefore, also the classifications provide directions. They may be used less and less in the future. Classically, there are 5 forms or precursors of multiple sclerosis. RIS and CIS count to the prodromal stage. RRMS, SPMS and PPMS are variations of multiple sclerosis. As the criteria for a definite diagnosis of MS has changed and been refined over the past several decades, it is now possible to treat individuals who previously fell into one of the preliminary stages. This helps to improve the long-term prognosis. Currently, the 2017 McDonald criteria are in place, but certainly there will be further adjustments in the near future. Let's start with the radiologically isolated syndrome, or short RIS. The diagnosis RIS occasionally occurs as an incidental finding when an MRI has been ordered for another reason. In this case, the MRI shows lesions at sites typical of MS, but which, so far, have not led to any noticeable relapses or impairments. Depending on their location and number, it is more or less likely that MS will develop from them in the further course of the disease. Findings that are associated with a higher risk to develop multiple sclerosis in the next 10 years are a younger age at risk diagnosis, oligoclonal bands in the cerebrospinal fluids, CSF, spinal cord lesions or infratemporal lesions. It might even make sense to start with a disease-modifying drug if there is a combination of bad prognostic factors. Second one, clinically isolated syndrome, or short CIS. One receives the diagnosis of CIS when there is a neurological dysfunction caused by damage to the central nervous system, CNS, that lasts at least 24 hours and corresponding MRI lesions, but no dissemination in time and space. MS later develops in 30 to 70% of CIS patients. Depending on how high the risk of MS is assessed, neurologists recommend immunotherapy already at this preliminary stage. This can help to postpone a second demyelinating event and definite diagnosis for many years. In any case, a close-meshed examination makes sense in order to be able to react quickly in case of further activity. Third, relapsing remitting multiple sclerosis, short RRMS. RRMS is diagnosed in 80 to 90% of patients at the beginning. This involves acute relapses that develop within a few days, cause symptoms, and persist for at least 24 hours. Few fade away quickly. Mostly the symptoms stay for several weeks or months and fade away over time. When using corticosteroids, this might be much quicker, but there is no proven advantage of corticosteroids in the long term compared to just wait and watch. The neurological reserve. The body repairs the damage caused to the central nervous system, CNS, by restructuring and using the neurological reserve. This usually works so well that symptoms often completely resolve initially. However, the neurological reserve is limited and is further depleted with each new lesion in the brain. Incidentally, only about 10% of all lesions are initially noticeable as symptoms. The other 90% damage the brain without being noticed on the outside. Be aware of hidden activity. So it can seem as if the disease is sleeping, even so it continues to be active. Over time, the body becomes less able to compensate for damage. The nerve damage successively becomes chronic. More and more limitations remain. Those who start as early as possible with a disease-modifying therapy, DMT, and a healthy lifestyle can positively influence their prognosis. Fortunately, there's now a wide range of drugs from mild to active and highly active course. Number 4. Secondary progressive multiple sclerosis, short SPMS. When the neurological reserve is used up, RRMS is followed by SPMS. The inflammatory activity decreases. Relapses no longer occur or occur only rarely. Instead, the effects of neurodegeneration, the death of nerve cells, becomes more and more obvious. The central nervous system can no longer compensate for the increasing damage. Without preventive treatment, meaning disease-modifying therapy or DMT, in combination with a healthy lifestyle at its best, 50 to 60% of those affected switch to SPMS after 15 to 20 years. Walking, in particular, becomes increasingly difficult. Cognitive abilities decrease and chronic fatigue usually intensifies. By the way, most people who go into early retirement due to MS have to do so as of cognitive issues. So far, as of August 2023, only a few drugs are available for the secondary progressive course. However, intensive research is being done. Number 5. Primary progressive multiple sclerosis, or short PPMS. 10 to 15% of those affected receive the diagnosis of PPMS at the beginning. This means that the neurological symptoms and associated disabilities increase steadily from the onset. Often there's a little or no relapse activity. The changes in the brain can now be visualized in special MRI examinations, but these are not yet part of standard care. So far, only drugs with CD20 antibodies have been shown to have a limited therapeutic effect. Significantly more research is and must be done here. The next interesting drug class might be the BTK inhibitors, who are interacting with microglia in the central nervous system. First phase 3 clinical trials might be finalized in 2024. Let's see if the results are as promising as researchers hope for. Summary. Currently, the best chances in fighting MS are the disease-modifying drugs, also known as immunotherapy, combined with a healthy lifestyle. Patients diagnosed with RRMS or RSPMS, the name given to the transition to SPMS, as well as certain cases of CIS, have a wide range of immunotherapies to choose from. For the progressive course, we need higher effective therapies, but there is for sure lots of efforts going on in that direction. So I'm positive that we will soon see results from that. Meanwhile, it is absolutely key to stay as active as possible to keep the symptoms small, or fight them back. And sports, as well as cognitive training, or even both trainings combined, show very promising results. I will take more on that with my interview guest in upcoming episodes. I hope this solo episode was interesting for you and you have now a better understanding of the 5 different stages we are normally using to define the MS for an individual patient. By the way, next time I will talk about the different types of treatment and prevention for MS. So I hope you tune in again and hear you next time. And please don't forget to subscribe to the podcast and recommend it to others who might be interested in the content. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. Hear you next time.